Thank you very much to all of you for coming here. I'm very honored by this invitation and opportunity to talk to the school with you guys. So thank you so much. Basically, what I do at LVS, for those of you who haven't interacted directly with me, is basically work in the management science and operations area. I'm a PhD coordinator there. I teach supply chain elective. I teach an operations management core course in the MBA program, and I'm about to launch a new open enrollment executive course in the area of supply chain leadership, supply chain management for executives. And my research is around the mathematical modeling of supply chain and global health delivery systems. In case you're wondering what that means, feel free to stay in the room for the next few minutes. All right, I'll start off by telling you a little bit about global health, because this is not really one of the core area that is typically associated with business schools. And so I'll start talking about global health by showing this little map here that is basically a map of life expectancy at birth in the world, and shows how heterogeneous and different it is in terms of how long you can expect to live at birth based on where you're born. And this wide variety really goes from more than 80 years of age to less than 40, 50, essentially in all of sub-Saharan Africa over here. So this is sort of motivates the focus on sub-Saharan Africa a little bit, despite the pronunciation challenges. And if you wonder why, so what's happening and driving these numbers is not as much the fact that many people live the same age on average, but what's really driving them is the mortality of infants shortly after they're born. And if you look at infant mortality, so that's another graph that shows. So basically in the UK, we're talking about 5 per 1,000 under 5 infants who die. If you're comparing this with other parts of the world, West Africa, Central Africa, we're talking about more than 220. So an order of magnitude difference by essentially 100, 150. So that's showing the magnitude of difference and discrepancies in the world. And the same map that I was showing you before, which is regular map of the world, you can basically morph it so that each country gets the area of the number of under 5 infants who die on a per capita basis. And if you do this again, you see Africa and the Indian subcontinent, some part of Southeast Asia, but really Africa and sub-Saharan Africa, essentially accounting for most of the infant mortality in the world. And that means in any given year, more than 6 million under 5 children who die. And a good portion of this, definitely more than 5 million of those children who die of conditions for which there is a easy, known, widely available treatment in the Western world. All right, so that's basically the moral component, if you wish, of why one would worry about global health. Do we want to live in such a world? The second component, and that's more related to business school activities, is the connection that there is between health and economics and development and metrics like GDP. And that's a graph which shows the association between life expectancy. Every point here is a country, and it's showing the association between the life expectancy in each one of these countries and the GDP per capita as a measure of wealth. And this association is a really deep and complicated one, because the amount of wealth drives the amount of health resources and treatments and facilities that are available. But there's another connection, which is that if you are sick, you're not contributing to the economy as much. And so that's a dual turn and connection that's essentially underlying this graph. So why would we worry about global health? I've talked about moral considerations. There's economic considerations. Another well-cited figure is that typically in a year, there's around 100 million people in each year pushed below the World Bank definition of the poverty line because of personal expenditure linked to a health event. So basically people getting sick, having to pay for it, and becoming poor in that sense accordingly. And then there's a third reason why we should all worry about global health, which is of pandemics, communicable diseases. I don't need to tell you much about Ebola and Zika and flu and so on. But it turns out viruses and bacteria, communicable ones, don't care at all about borders, and they care even less that borders are more and more porous with flights and travel and so on. So there's a number of very different reasons why global health really is one of the world's most pressing, important challenges of our time. Now, what's being done with it? Well, there's a lot being done, of course. I'm going to talk about this, but if you're looking at this in terms of resources available, that's the same kind of map I was showing you before, except I'm showing the number of physicians per capita. And what you see, again, are huge discrepancies. So Central Africa, on average, 7 doctors per 100,000 people, compared to North America, not that different from Europe, where you see 433 doctors per the same number of people. So again, an order of magnitude of several hundred, about 100 in the concentration of doctors. If you're looking at maps showing the concentration of nurses, pharmacists, or personal health expenditure per capita, they all show the world in a similar lens. So that's one component of what's there available. And then another component is that not everything is gloom here. So there's been a really substantial increase in the total amount of development assistance for health. So essentially, the high-income countries pulling together through various channels in order to raise money and make it available to fund health programs or health interventions of one sort or another to medium to low-income countries. And so you see that in the, since roughly 2000, there's been a really sharp increase, tripling, in fact, of this total amount of help from the rich part of the world, going through about 30 billion per year, which is now sort of tapering off. And what's driving this are things like the Global Fund, the Clinton Health Access Initiative, the Bill and Melinda Gates Foundation, the Gavi Alliance for Vaccines, and other multilateral initiatives of that kind. So that's the good part of the picture. The more concerning part is that 30 billion per year is nowhere near the level required to meet Millennium Development Goals and many minimum health standard metrics. And the second thing is the allocation of this help. So you see here the different ways in which this money is being used through the world. And because of the specific channels that have driven this increase, you see that there's a really high concentration going to HIV, maternal health, malaria, and tuberculosis. But if you're looking at non-communicable diseases and general health sector improvement, things like training physicians, developing health infrastructure, clinics, hospital, it's in fact a very, very tiny fraction. So there's a very drastic misallocation of financial health resources to the actual needs in terms of health requirements is what's really affecting the health of a large number of people. And so really there's a fairly wide consensus on strongly neglected but key areas of global health. And these include non-communicable disease, things like obesity and tobacco epidemics, and other non-communicable disease, cardiac-related, and so on. There's one area which is completely neglected, which is mental health. So if you have depression or some anxiety disorder, bipolar, schizophrenia, in most of the low-income parts of the world, there's really nothing in terms of resources. And that was pointed out, by this Nature article that, really shows a picture from just 4 years ago. And then the third point on which a lot of people agree, there's a really drastic need, or what's called health systems. So that's related to this working physician. So the systems needed to make sure people get delivered the healthcare, they need access to specialists, access to products, access to diagnosis, the infrastructure. All of this is quite neglected at present. So how did I get into this? It didn't start out, I mean, I would have liked to get into this much earlier. It turns out everyone in my family, or almost close to that, is a medical doctor, physician, and really literally everyone. So I'm the doctor in the family that can't fix people, as one of my nieces, would say. Or you're the doctor that does math, but and probably signals the start of the boring part of the work-related conversations in family dinner parties and things like that. So I was working on supply chain modeling. This is what I was doing really just before joining LBS. And I want to, I said I was going to try to explain to you what that meant, mathematical modeling of supply chains. And I'm going to try to do this by showing you 2 slides and a video, and I'm going to show you this because it's going to be related to part of the global health work that I'll be doing. So I've been working with Zara for more than 10 years now. I'm basically one of their primary technical consultants and collaborators. I've written many papers on systems that we've developed with them, that they've implemented and things like this. And one of the challenges that I started working on is the orders and the distributions from all of their stores, about 2,000 of them, from the warehouse to their stores. And it turns out they've got this really, if you go to Oxford Street and check out their clothes, it really changes all the time. So lots of shipments, lots of different garments, lots of different sizes. So they basically need to make more than 64 million decisions per week in terms of the quantity of every size of every article to ship to every of the store twice a week. And I started, part of what I did with the beginning of my career was build systems that were solving these kind of problems and making sure maximizing their profit when these decisions were being made. And the kind of thing, so that's kind of the picture component. When you read a paper about this, it looks more like this, which is why I'm not going to tell you exactly about what that is. But instead, and again, that will be relevant to understanding what supply chains are and this research work, I'm going to tell you that in Zambia and sub-Saharan Africa, I'm going to show you a video of what that kind of thing looks like when you implement it in practice, right? So as you watch this, try to follow the blue jacket. There's a really nice blue jacket. And instead of following medicines, we're going to follow that jacket.
The distribution process begins at the store level, which is the visible face of the company, and is where there is the best understanding of what customers are demanding. From a distribution standpoint, there are 2 key pieces of information that are gathered at each Zara store. The first piece of information is the point of sales data that is captured daily and is transmitted directly to Zara's logistics center in Spain. The second piece of information is the bi-weekly order placed by each store. On the day they have to place an order, the product assortment for the next shipment is downloaded into a handheld device.
2 veces por semana hacemos el pedido de la tienda a la central, incluyendo los artículos por los que apostamos después de escuchar a nuestros clientes, y completamos los artículos destallados.
A very important aspect has to do with the availability of sizes. Most stores will only display merchandise for sale when the set of available sizes is complete enough. This is meant to achieve a balance between keeping inventory displayed to generate sales and mitigating the impact of missing sizes on brand perception. Therefore, if at any point in time a store associate realizes that the major sizes of a given article are missing, then it is likely that all remaining inventory of that article will be moved from the display area to the back room, especially if the same space can be used to display another product that is available in most major sizes. This way, the incomplete article is effectively removed from customers' sight. When preparing the bi-weekly order, the store manager will go through all the articles in the store and will also check in the back room for products that were removed from the shop floor because they were missing some of the major sizes. Zara has a fixed schedule of when the orders must be placed. The store manager is responsible for transmitting the information electronically by the cut-off time. The ordering process is repeated twice a week at each one of Zara's 1,500 stores for several hundred different products. The point of sales data and the orders from the entire worldwide network arrive at Zara's headquarters in A Coruña, Spain. The information is centralized and stored in the legacy database that is managed by Zara's systems area. Overnight, a subroutine automatically computes the sales forecast for each article at each store. The forecast is based on a regression model, and at a high level, its structural form is a weighted linear combination of the two key pieces of information gathered at the store level. That is, on the one hand, the objective and centralized time series data of historical sales, and on the other hand, the subjective and decentralized shipment request, converted into a sales prediction by taking into account store inventory. Once the forecast has been computed, the distribution team comes into play. This team consists of approximately 60 employees. Their responsibility is to determine the exact number of units of each size of each article that should be included in each shipment to each store. Therefore, they are the main users of the inventory allocation model. Each employee has access to the central database through a client application especially developed for this project.
Para cada artículo, el modelo recupera la estimación de la demanda y el stock de las tiendas y del almacén. El usuario puede modificar los parámetros disponibles haciendo un clic y el modelo optimiza la distribución del stock.
El modelo corre en un servidor dedicado para cada centro de distribución. Está codificado en Ampel y se resuelve usando Ceplis. Cada caso se resuelve en escasos segundos porque disponemos de muy poco tiempo desde que la información está en el sistema. Y en una semana normal, aproximadamente, podemos resolver unos 15.000 casos para distribuir 6 millones de prendas valoradas en más de 120 millones de euros.
The user at the warehouse can visualize the solution of the model through the client application. The interface allows the user to request additional runs of the model in order to perform what-if scenario analysis. For instance, depending on the time remaining to the end of the season, the user might modify the aggressiveness factor to push more inventory to the stores.
Si fuera necesario, los usuarios pueden hacer cambios en el modelo. Estos cambios los solemos hacer cuando nos afectan factores que no captura el modelo, ya sean festividades, ya sean cambios climáticos, cualquier tipo de cambios que nos pueda afectar a la distribución en general.
The chosen solution is finally transmitted to the existing warehouse control systems, which effectively implement the physical picking, sorting, packing and freight loading operations. The warehouse is divided into two distribution areas, one for the hanging clothes and one for the folded clothes. In either case, the first step to implement the model's output is picking the items in the solution. This is done in a wave-picking fashion, in which the same article is picked at once for all the different stores in the next shipment. The second step is sorting, so that different items going to the same store are put together in the same shipment. For the hanging clothes, there is a dedicated rail for each store, and for the folded garments, a state-of-the-art sorter is used to place each item in the right shipment. Barcodes are used to identify the type and destination of each item and to tell the sorter in which box to drop it. Shipments are made by truck or by plane for more remote locations so that the items reach the destination store within 48 to 72 hours. In the case of ground transportation, the trucks are loaded directly at the docks attached to the warehouse. In the case of stores that are reached by plane, an air cargo container is filled at the warehouse, which is then transported to the airport and loaded onto the aircraft. The shipment finally arrives at the store where the items are unloaded. The store associates check the products and quantities that arrive, which might be different from what they originally ordered, depending on the optimization performed by the model. Most of the items will be placed immediately on display. With the new shipment, the store associates can now complete the set of sizes of an article that was moved to the back room before the previous order, and the entire article can be brought back to the display area. Indeed, the model allows to send only the missing units in a size profile, so it constitutes a good display. Once it is back on display, the article can effectively generate sales without affecting customer perception due to missing sizes.
So you're probably wondering, why did you come to a lecture about global health and end up seeing a quasi-commercial about Zara? I think I wanted to show you first where I was coming from. And this is a journey which is not uncommon to other business school faculty that I'll tell you about at the end of this talk, who likewise are interested in emerging economies and markets. And two, I wanted to show you essentially what is meant by a supply chain. And so I use this video in several of my courses here at the school for this former purpose. And what this shows is basically everything that's under all the physical goods that basically surround us, all the infrastructure, all the management problems, all the transportation, warehouses, and so on, that ultimately are combined to make this flow of goods available. All of this, obviously, is a very high-income private sector company. So how did I move from there to talking about global health and delivery of essential medicines? What happened in 2010 is, after I did this work and basically had just published it, I got an offer to come from Boston University, where I was before, to London Business School. And one of the things that I really liked about London Business School was that it seemed very serious and genuine as an institution in terms of the impact that it cared for research. They wanted research and the teaching to have in the real world. And so given the kind of work I was doing, I felt this really resonated very well with me. So that's the first thing that happened in 2010. And in a second, you'll see the picture of somebody I met at one of these presentations I was giving to various universities of the Zara work, who basically was somebody who was working with the World Bank, and so specifically the Human Development Group of the World Bank in Washington, and a person called Monique Vleder, who was heading the World Bank interventions in Zambia and Zimbabwe. And so that was another professor from Michigan who also had been doing supply chain operations. And tell me, this work about you've done with Zara, it's exactly the same challenge that we're facing in Zambia as part of this collaboration I'm doing with the World Bank in that country. And I was pretty skeptical at first. And basically what you can find out about Zambia is that it's a country landlocked in the bottom south part of Africa. It's got about 12 million people there, and very poor country. And then in terms of health, very much aligned to the picture from before. 40 years life expectancy, 40% of the population suffers from malaria, 16% live with HIV, and there's diarrhea, tuberculosis. Malaria is a very tragic killer in Zambia, and likewise it primarily affects children. So what that means, just focusing on one of these maps again, these are the number of deaths, about 600, so 500,000 or so every year. People die from malaria, and this is where they die. So Zambia is that country here, even though it's got 12 million people only. And that's 85% of those deaths are basically, again, under 5 children. So what's the problem? There is an effective medicine to treat malaria that's called artemisinin combination therapy. And that medicine, if it's available and administered at the right time to an infant with fever and the symptoms after they pass the test, is effective. It basically entirely cures the disease. So the problem is that that medicine is not available at the point and time when it's required with an infant having a crisis. And so there's lots of evidence of this, and people who've done some checks of availability level in pharmacies. This is in EU countries, the average availability level in percentage at pharmacies. So for most of these countries listed there, above 95%. That's the European average. If you go to clinics in sub-Saharan Africa, it drops down to barely above 50%. So every other drug is not there. And the problem is that these drugs are not there, tend to be the ones that are most important from health standpoints. So there's tons of surveys of what drugs are missing and so on. But overall, it's really a well-known crisis about drug stockouts that's really acknowledged. And so the issue is that, of course, it's got a lot of impact on morbidity, mortality, and so all of this is really well known. What I want to talk about is why it's difficult, looking at the case of Zambia, to get those drugs to the clinics so that they're available to patients. So there's issues about road infrastructure, communication infrastructure, electricity infrastructure that are common to low-income countries. You also have this unreliable supply of drugs into the country, in part because of this national funding shortfalls that I was describing before. You also have seasonality in demand. So basically, demand in malaria cases, they go with the rainy season, which is very strong in that part of the world, mosquito population. So you see this incidence level really changing drastically with peak demand in the second quarter or so. And guess what? This is also when it's hardest to reach the facilities because there's flooding. So this is satellite imagery of essentially all of these little islands are created in the country due to rains and flooding. So it's a very challenging problem to distribute drugs and make them available. How they're solving this is basically through this national distribution system, which accounts for about 85% of the volume of medicines being distributed, where suppliers deliver to national warehouse, this primary distribution to district store, secondary distribution to health centers and hospitals where patients basically get care and products. It's this monthly replenishment cycle, entirely paper-based, and there's not enough vehicles primarily in the secondary distribution phase, and there's also drastic shortages of staff, so overworked staff at the clinic level. So these are the main challenges. Now you remember this video I was showing you about Zara. I'm going to show you now pictures of what that supply chain looks like in contrast. So that's the national warehouse, which the donors basically tend to visit during their trips to the country. So Bill Clinton has been there, Barack Obama has as well, and so on. And so you see the difference with medium income and even some high income warehouse is not that different. So forklift, trucks, information systems, trained staff, following inventory, stock keeping procedures, and so on. That's the primary distribution. So fleet of truck, dedicated one, well-maintained, traveling on mostly tarred roads. This is the district where basically they reach after this primary distribution, about 70 in the whole country. Likewise, stocking condition in terms of temperature, control, humidity are still fairly good. Security conditions are well as well. Stock keeping procedures. You start to lose IT systems and computers for managing flow and tracking transactions there. Where the real challenges begin are basically beyond the district. So these are pictures showing what it's like to go from a district to a health clinic. And this challenge is due to the state of road. This is during the dry season. So you imagine what it basically becomes during the rainy season. And it's basically really hard to reach those facilities and very expensive comparatively as well. And these are pictures from health centers. So architecture a bit reminiscent of Soviet era, not a lot of, so no temperature control for the medicines, and drastic stockouts. And I visited a number of these places, and it's a very moving experience because you see shortages of drugs, and this is what I was sort of coming to understand and interview people and so on. And what you see is basically a lot of suffering people. So the people going to there maybe after a half day of walking from their home, carrying a infant with fever, they are very poor, but they know what likely it is that their feverish infant has. And the fact that they're poor doesn't prevent them from really understanding what's happening and really understanding the implications of doing this half day of walk and not finding artemisinin combination, therapy of intravenous quinine and so on when they get there. So it's a little bit difficult as a field research experience, and it's certainly really striking one. So I came in that person I was introducing you before is doing this work with the World Bank, investing into experimenting with different configurations with supply chain. So putting different people to try and help with inventory management, trying to do cross-docking at this rate. So they had this large-scale experiment where they were measuring things and basically pulled me in and said, hey, you've done this large-scale experiment with Zara. Why don't you try and help us analyze the data and really understand what's happening and what's driving performance? And that's really how I was brought in. Of course, raising in a family of doctors and being the doctor that can't fix people, that seemed like a natural fit. I was really eager to do this. And then I still love working with Zara and have great friends there, very smart, hardworking people, exciting company. But I must say, this also sort of filled a bit of a gap in terms of meaning and of research and stuff for me. So that's also why I went there. So they did this intervention in a number of different districts. The main challenges we had was how do you get data in those places where you really want to measure stock out availability and so on. There's oftentimes no electricity, computers, Xerox copiers, and yet we wanted to collect large amounts of data. So the idea we had late night in a hotel bar in Lusaka with my co-authors were to basically do this with digital cameras and say, okay, that's the most effective data capture. We have these commodity planners paid by the World Bank who basically travel around. And so the following day, we went to the one single electronics store in Lusaka, bought 20 digital cameras and said, once we have the picture, we'll always find some people to do the data entry and digitize the picture of the stock cards. So the way it worked was this paper base where you record all of the input of inventory, stock ledgers, basically, that they kept at the clinic. And we had hundreds and hundreds of these, almost 1,000 of these photographs taken. And then we send them to this firm we had found located in Laos, who were basically employing people to do data entry for research support purposes, double-blind data entry, so this was really reliable. A little bit labor intensive, of course, but in the end, we got a digital data set from this process that told us this time horizon and time availability of drugs and let us understand what were the common patterns and when were and why drugs basically stocking out. And so we could get consumption, periods of stock out, local demand of estimates, and lead time as well, because we had the timestamps for when things were getting in. And what we realized was this, first of all, definitely stock outs, but very a lot of inequity and vast differences in where those stock outs were happening in terms of location. And so this point, a point here is a facility. And based on how long it was from the warehouse, the lead time from the warehouse to that facility, this was really driving quite a bit the difference in service level. Where here, service level means if you got 60%, basically 40% of the time, you don't have the medicine. So we realized this. Well, we also realized that because we could get this complete curve of shipment and inventory and stock out of the time, the typical pattern involved having a peak demand season, and that was for a number of products, including antimalarials, and that was due to, see first quarter, January, February, increase in demand for malaria medicines. And then we would see inventory basically going up and down with every shipment before, but then really going down in the peak of the demand season, the orders, the shipments basically drastically increasing there, but a lot of stock out because those higher shipments would only arrive after essentially the peak demand season was over. And that's the kind of observations we made. So when we tried to understand why, is it that there is a stock out at the warehouse level at the exact same time? We went there and from their record plotted the inventory level of the same drugs over time. And what we realized is that the same period of time where we see a lot of stock outs basically corresponded to times when the warehouse was flooded with inventory and it had a ton of inventory. So what we knew is it wasn't a procurement, national funding issue. It was really a distribution one. It was something that affected the process from the warehouse to the clinics. And so we went further into this And so without really getting into too much of the detail, we realized it had to do with what's called inventory control. So the nervous system, if you wish, how they were determining how to replenish and the quantities. The exact same problem that I had been working at Zara, determining what's the quantity of what kind of medicine that you ship to what facility at what point in time. So this was the same area, realm of inventory control, although we didn't know this at the beginning, but it turned out a lot of the methods and finding and results, as a result, became quite applicable. What they were doing before in this sort of paper-based system was essentially tracking what they call the average monthly issues over the last 3 months. So averaging over the last 3 months, what were the issues, and then ordering enough to replenish the stock to a multiple of these monthly issues over the last 3 months, which in a setting with seasonality was really harmful. Because if just before, and really explained this kind of behavior, if just before, just as you see demand increase, you're not going to order more because you're anticipating that the demand is going to increase. You're ordering based on your last 3 months, not the next 3 months. And they were doing this because of restrictions in information systems and forecasting and limitations in capabilities and skills of the health workers and so on. So so this was directly explained, and then at the time then, demand increases, so the average monthly issues would basically increase during the demand period, but they were not really anticipating the increased lead time due to the flooding and access issues and so on, so that when they order these higher quantity they were ordering too late, when they came in, when demand has flattened out already, this was creating a mountain of inventory worth 6-7 months of demand in stock at that point, even though they had monthly replenishment opportunities. So that made no sense whatsoever. Really high stock out during the rainy season, and then a lot of inventory and so on. So this is what the current system was doing. And what we also realized is that this was not just happening in Zambia. The reason why they were using this particular paper form, which were implementing this monthly issue business, is that those were disseminated and advocated and taught by subcontractors of a number of development agencies, including USAID, which was the most impactful of all of these organizations. And so even today, if you go on the web and check out the documentation that maybe a supply chain manager in a low-income country would basically try to get in order to manage a pharmaceutical supply chain, you find beautifully arranged, laid out documents which basically tell you that you should be doing this. And those documents and this policy, it turns out, is used in the majority of countries of sub-Saharan Africa, even today. So what we set out doing then is how do we leverage these better, and in this particular environment, trying to be cognizant of the resource constraint and the infrastructure constraint. What do we do about this? So very comparable to Zara, instead, about the same number of delivery points. It was a problem that involved a lot of rationing. So many times in the central warehouse, they did not have enough medicine, and so they had to ration, limit the quantities that could be sent out. They were doing the same thing at Zara, although not by constraint and due to funding restrictions, but by deliberate choice. And you've probably heard, if you've been in any of their stores, that if it's deliberate on their part to not have a large number of items that are all the same, because they don't want everyone to look the same, and they also want to make sure that when somebody really likes an item, they're going to go ahead and buy it right away, as opposed to wait for later. So these are very different reasons, but what you have to solve in terms of supply chain management problem is basically very close as a result, which is there's not enough inventory for all of the delivery points, and you need to build in system that help manage this rationing. And of course, there were challenges that were different in terms of delivery times, demand, and objectives. So this led to different types of models, and I'm not going to go into the details as well. I know it doesn't look that different at some level, but in fact it was. So some components were pretty close. We were able to leverage learning from Zara and what worked and what didn't work, and some components were quite different. In any case, when we simulated what happened and tried to evaluate seriously the potential impact of using a different way of managing inventory control, we realized that using this kind of model would move their availability from that kind of picture, which is the current state of what I've showed you before, to a system where before the peak of demand, taking into account the lead time in advance, you'd start sending much higher shipments so that the inventory matches the demand curve. And by doing so, this assumes exactly the same level of inventory as in the previous picture. You basically eliminate stockouts completely. So the potential, I mean, now there's of course a lot of issues about implementation challenges and infrastructure and IT and computers, and I'll tell you a bit about those. But basically, conceptually, if you manage to overcome these challenges, you could eliminate stockouts entirely, all right, with the same amount of inventory, like-for-like conditions. So specifically based, oh, anytime.
It might be a really basic one, but because it's healthcare, with the demand, how do you know when you get that dip in demand, so where it goes up? How do you know that's coming?
Yeah, so that's conceptual picture. But what happens is, for some products, you don't. When there's an epidemic of cholera, for example, at the border with Zimbabwe, that's not a regular seasonal issues. But when you're looking at malaria, that's very, very seasonal and reproducible from one year to the next. So so there's public health specialists do models to predict based on weather, precipitation, forecast, and other factors exactly what demand. So that's actually fairly not straightforward, but really very feasible to predict. Yeah. So what we saw was that more generally, taking into account the rationing, we would raise the current availability level from 60 to 80%, depending on the assumption, to near 100%, and that the previous picture showing the inequality in different regions would basically also be addressed with some facilities at the 80% level, but really most of them near 100%. So, and this inequality issue, in addition to the overall average service level, is very sensitive because these are life-saving products, and this is a public system. So in a public system, distributing life-saving drugs is very important that from a political accountability standpoint, all regions have equal access or comparably good access to medicines. And what happened in the end of that part of the story is that based on these results and simulation and some tryouts, the World Bank started a partnership with the Ministry of Health and IBM in order to develop the IT infrastructure that would be compatible with the local environment. So that would involve, for example, robust, solid smartphones, so they call this rugged, and with barcode scanners in order to facilitate the data capture and digitize the transactions of the supply chain, just like in any high-income, time-sensitive supply chains. You say, you can even check the DHL tracking locations, and many of you guys done this. But to implement this kind of digitization and traceability in this environment where you can only reload smartphones by solar panels, and you need to transmit information from places when there's no network coverage yet by using some USB keys that are shipped around and updating in an asynchronous manner. So there's technical issues around this, but they started out basically developing the system, and I'm hoping that in the next month or so, this pilot that has been approved of that kind of technology will yield some results. And that's the story about Zambia. Rather than telling you this has led to other types of, it was a foray, if you wish, into global health. Now, what made me realize that there was a large opportunity because the research was interesting, the problem was important, it was very satisfying, and so it was essentially both meaningful, but also sort of professionally and academically a feasible endeavor for me to invest. And I've decided to continue working on both high-income private sector supply chain challenges and global health, because I think that this transfer of knowledge and the perspective that this brings is one of the things that has been missing from the field of development, global health. So I just want to briefly mention this, this new project that was just completed, and that's a paper with my current PhD student here that Judith knows very well for having brought him in. But Jonas basically is about to defend a dissertation on this problem of how you optimally design a laboratory network to diagnose HIV in kids. And so this is another project that I've just completed now. And it turns out likewise is an important challenge. It really has an impact on a number of children living with HIV or being treated in a timely manner. And is also very challenging and interesting from an academic standpoint. And it's also an area that's starting to be recognized in a number of other business schools. And I'm really delighted to say that Jonas has just accepted an assistant professor position at the same university in Boston that I was working, which is the Massachusetts Institute of Technology in the Sloan School. So there's other, besides LBS, there's other top research institutions who are also paying attention and I think believing that this is a very important area for business school faculty and research to go into. So I'll skip the details for lack of time, but I want to offer a conclusion. So one is I've just mentioned two different projects. Jonas and others were working on a number of different things. It turns out that this one of things where it basically expands the number of interesting problems you come across, and interesting opportunity becomes way bigger than I currently have time to go after in light of my other commitments. And one that we've started to work on is how you design maternal and neonatal health infrastructure. So likewise, an area when there's no mathematical modeling, existing guidelines are very coarse. So WHO guidelines for knowing how many midwives, where you put them, what should be their training, what should be the equipment level of maternity and delivery clinics are very, very coarse, not really based on any rigorous, serious modeling, mathematical policy analysis of the kind we're doing. And we're collaborating with researchers from the London School of Hygiene who bring the contextual knowledge about maternal health. And so that's really exciting as well. But basically, in conclusion, I wanted to convey that global health was important for a number of different reasons. I believe it's important to everyone. Moral reason, health reason, and economic reasons. I think there's really exciting and important research opportunity associated with the delivery component of global health. So how health and product and care are being made available to patients, as opposed to inventing a new drug or a new treatment, but making sure that those are basically accessed by those who need it. And then I've also wanted, perhaps more generally, convey that the kind of research knowledge and skills which is all around us in places like LBS and business schools, research-oriented business school, is potentially useful and impactful to address not just health delivery systems, but really development and emerging markets more generally. The research on this area is so strong at LBS. Basically, between us, Stanford got a lot of money that they don't know how to spend to do work in this area. And we're, thanks to the great work of the advancement team and many other people, we're certainly getting some money, but nowhere near what they got to focus on this particular area. But what we have, though, is a really strong group of faculty who independently and spontaneously, regardless of money raising motivations and agenda, are already doing this kind of research. So you may have heard or listened to Rajesh Shandy, who does work on what kind of entrepreneurship, business school education works for micro-entrepreneurs. You may have heard work by Nofal Vilkasim, who is looking at how entrepreneurs in emerging market can be supported and what are the most effective consulting and coaching channel, leveraging communication technologies and MBA students or young professionals who want to volunteer by helping people trying to make it as micro-entrepreneurs in Africa. You may have heard about Kamalini Ramdas, who is working on with a former PhD student from the marketing group, Stephen Anderson McDonald, I think, now working at Stanford because of this huge donation, are working to understand what are the sources of disruptions that are most accounting for the largest number of bankruptcies of micro-entrepreneur businesses, and what are the most effective strategies for creating resiliency for that kind of economic activity. I could mention Elias Papaioannou, who does work to combine satellite imagery of light patterns in Africa to understand the drivers of development. Is this linked to political intervention, ethnic origin, tribe, and so on? So and all of this is across LBS. Faculty I mentioned are in MSO, Kamalini, marketing, Nofal, Rajesh, economics, Elias. So this is an area that really is already spontaneously, independently very strong across the school. And all of this work by my colleagues I find really very exciting. We all know each other and we really find our work very interesting. So I want to leave you with an idea that maybe we could consolidate this and leverage this existing set of research activities and really strong differentiating factor that's very genuine by creating something like an institute that may solidify the perception and build this into our brand, build this into our recognition for emerging markets. And I want to leave you with this before, maybe taking questions if I have time, because this is my one opportunity to address a sort of cross-cutting section of the staff here. I want to acknowledge the part of the LBS staff that have contributed to my research in particular. I'm very happy. Don't tell this to the Deputy Dean for Faculty and Research, but I can't believe I'm paid to do my work sometimes. Make sure you don't tell Stephen, okay? Don't tell him. But LBS is a fantastic working environment for me, and everyone in the staff is contributing to this. But the part of the staff that really is making a difference for my research, I first want to acknowledge Vicky, who kindly came here, and I didn't have her do this, didn't ask her, but Vicky, my assistant, is really a godsend, and I'm really privileged to work with her. So thank you. Other MSO staff are really great as well. The RFO office, okay, Rosemary, Judith, and everyone working with them are really working hard to help and support research faculty. PhD program office, Judith, thank you. Many of this work was done with PhD students. There's an enormous amount of work that gets into this. Our PhD program size is very small. Maybe this Institute of Emerging Market could lead to expanding this, I don't know. Some ideas. The Deloitte Institute has been funding a lot of the kind of research that I was mentioning, and that's, of course, thanks to work from many people. Central Services, by allowing me to have a term where I teach and other part of the year where I can do research, so the kind of decisions that are being made and scheduling, they really impact this. Marketing and communication libraries for accessing. So anyway, thank you very much for coming here, listening to me, and any questions, I don't know.
Thank you very, very much. I didn't hear you say what you were going to say. I did hear you say it, and I agree about the opportunity that we have to essentially try and group these activities together. I think there's a tremendous agenda that's going on here, and actually, I think it's really important. So that is not, that is only. I think we're coming very much out of time. And there's one burning question. Maybe I know Jeremy has a second to say afterwards if people have individual questions. Yeah.
Maybe just like a technical question. Are these sites available, and are you happy
most of them I could share with that problem. Some of them I might need to ask my co-authors, but most of them, and so part of this material about motivation is in the global health module that I teach in the new health management elective. So it's already, being distributed to students, and some parts of the research, because I could easily put this together and make this, or a subset of it, big subset available if you're interested.
Yeah, thank you for sharing. It's very interesting. I actually come from a public health background, and supply chain management is a huge challenge in African countries, particularly. And it seems like a good project if the results, if the results turn out well. I think you said the World Bank is running or helping to run the program with the Ministry of Health in Zambia, and I know supply chain management is a challenge, but some other areas that affect something like malaria are like health education. You mentioned one issue of people having to walk to health centres, and I know in some places, because they have to walk very far, they don't bother, or they different cultural reasons. So we're really interested to see how it turns out, and it would be a really good component for like a community health program, which would run health education along with supply chain management, different areas to address each issue.
Thank you. So what I presented is basically a small subset of projects linked to a small subset of opportunities for having an impact, and clearly it's very selective, and so I don't mean to pretend that this work should receive any sort of priority in the agenda, nor that it should be really qualified in terms. But interestingly, Jonas and I, the second part of his dissertation is about how you deploy community health workers for exactly the same kind of reasons you were mentioning, which is it's really hard to get products, and so can we also improve the connection between basically trained health professionals living in villages with extensive knowledge of the local areas, but who have been trained to address well-identified needs for advocacy, education, but also treatment. So for example, doing a malaria test, administration, malnutrition, pneumonia, and so locally relevant health interventions to go around and visit households. And we obtained this data set from almost 1,000 community health workers through 2 years, I think, in 5 different countries, where we get timestamps and GPS stamps for every interaction between the community health workers and households. So we get to understand how far they get to travel, what kind of data they're collecting, how long and what of a catchment area they can cover. And so we're looking at models to try and inform policy recommendations for how you deploy that kind of workforce. But it also reminded me of this more general observation about the funnel. So this is an area where the more I get into work into some specific things, the more really important, interesting problems I basically come across. And your question illustrates that.
Yeah, it would be a good model if it works well to use in other countries. I know organizations do that. They use the same models in other contexts, and they have to tailor it.
Thank you very much. Thank you for coming, everyone. And I think we'll leave it there until Jeremy will be available.
I would love to stay if you want to chat.